Good evening, everyone. My name's Michelle Batty, and I'm the manager of the EUROGEN web programme. Just before we get started, I'd like to take a couple of minutes to describe what our ERN is and a little bit about what it does. So EUROGEN is one of 24 European reference networks that were created, and they're also funded by the European Commission since 2017. They all deal with patients with rare diseases and complex conditions that need highly specialised healthcare. And we deal with rare urorectogenital diseases and complex conditions. So mainly where highly specialised surgery is needed. And we're currently a network of 56 hospitals in 20 member states. So we aim together as a network to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So really where the expertise is rare. So some of our activities, firstly, as you may have noted from the slides at the beginning, we can deliver virtual cross-border consultations using a highly secure platform called the Clinical Patient Management System, which is provided to all the 24 European reference networks by the European Commission. So we are able to, free of charge, gather some of our experts together and deliver specialist advice. So please, I would strongly encourage you to get in touch with us via our website or the email address you saw at the beginning. We would be absolutely delighted to deliver advice on any of your tricky or complex cases. And as I mentioned, this is completely free of charge to any healthcare professional working in the EU or EEA member states. In addition to that, we do training and education activities like this webinar programme. And we also collaborate on producing clinical guidelines and clinical decision support tools. And we aim to do that in collaboration with the scientific societies as far as possible. We also have a very exciting, relatively new development. We have a patient registry, and this is currently being rolled out across all of our healthcare providers. This is going to be a really important tool in the future, as it will provide the evidence for our guideline work. And of course, it can also identify the gaps where future research is needed. And then finally, we have produced a really fantastic book, Rare and Complex Urology Together, which gathers together the latest evidence-based scientific knowledge on all the areas covered by our European reference network. So without further ado, it's a great honour to introduce two of our Italian experts, and they're talking to us today about the management of male incontinence in radiated patients. So our speakers today are Dr. Riccardo Bientinesi, who is a urologist at the Agostino Gemelli Hospital Foundation in Rome. And we also have Professor Emilio Sacco, who is also a urologist, and he's chief of the urology department at the Gemelli Isola Hospital in Rome. So as you know, urinary incontinence is a very common problem in the world population, and it has a really negative impacts on the quality of life of the patients. So radiotherapy may worsen incontinence. So the choice of a tailored management for radiated patients is crucial for optimal results in continence recovery. So we're all really looking forward to hearing more about that. And just to note that this webinar is eligible for CME accreditation points for those attendees who attend this live and complete the survey at the end of the webinar within 2 weeks. So thank you very much again to our presenters, and Riccardo, you have the floor. Thank you.
Hello, everybody. Thank you, Michelle. I'm just sharing my screen. Okay, so good evening, everybody. We are going to talk about medicine implantation for post-prostatectomy urinary incontinence in radiated patients. I have no conflict of interest. Let's begin from prostate cancer. Prostate cancer is one of the most uncommon cancers in men. Often the treatment is surgery. The treatment for prostate cancer is radical prostatectomy. In some cases, radiation therapy may be proposed as an alternative or as an integration for surgery. As consequence of the surgery and also as consequence of the radiation therapy, urinary incontinence is a very frequent side effect. Urinary incontinence is defined by the International Continence Society as an involuntary urine leakage. The urinary incontinence in men is a very common problem. The incontinence affects about 25 to 50% of men after radical prostatectomy. Often the type of incontinence is a stress urinary incontinence. That means that this type of incontinence is as a consequence of a stress, like a cough or some similar. And this condition is going to affect the patient in his daily life. As a great psychological impact, cause a significant psychological distress. Incontinence can lead the man to anxiety and depression, and also a social isolation, because a man who is incontinent tends to avoid normal common activities and human interaction. And also, incontinence leads to a decreased physical activity. So you can understand well that is a great problem for a man to have a urinary leak. What is the pathophysiology mechanism of incontinence after radical prostatectomy? First, muscular weakness. During the surgery, the urinary sphincter can be damaged or weakened, and so this may lead to an incompetence of the urinary sphincter. Second, a nerve damage. Nearby the prostate, there are some nerves deputed to the erection, but some studies have demonstrated that these nerves can also have a role in continence recovery. So a nerve damage during the surgery, or also due to the radiation therapy, may lead to urinary incontinence. There is also another mechanism that is a prolapse of the urethra after radical prostatectomy that leads to an incompetence or not good closure by the urinary sphincter. Radiotherapy may worsen this scenario because radiation therapy leads to tissue damage. Radiation therapy may make the tissues more fragile and increase the surgical risks for incontinence correction and worsen the incontinence. Radiation therapy may also lead to scarring of the tissue, and these make harder for slings or other solution to work effectively. And in general, radiation therapy may make more complicated any treatment after radical prostatectomy. As you understand, treating urinary incontinence in a radiated patient may be a challenge. Why? If we can think that we have some options to treat urinary incontinence, I am talking about slings in urinary incontinence men. Sling implantation in men who had a previous radiotherapy may have a lower success rate because this is a result from a large meta-analysis that shows that the radiated patient may have lower odds of success comparing to non-radiated patient after sling placement. Also, radiotherapy may lead to increased complication rate after sling implantation. These complications can include infections, erosions, and then also a revision, a surgical revision of the sling. We need to talk with the patient before surgery to better manage the strategies and tailor the treatment to the patient. As I said before, we have, in conclusion, two main treatments to offer to the patient after prostatectomy and after radiation therapy. From one side, the male sling, that is a minimally invasive procedure, and to the other side, the artificial urinary sphincter, that is a more invasive and cost-effective procedure. How does a sling work? The sling offers an urethral support. The sling placement the sling is placed around the urethra and provides a support and also a tension that can be intraoperative adjusted, or there are some adjustable sling which tension can be adjusted after the surgery. So the patient can regulate the tension in consideration of the leakage. The sling is a minimally invasive procedure. Is less complex than a sphincter implantation, but as a consequence, in radiated patients that often have a major incontinence cannot be so effective as in a curative scenario. How to follow a patient after radiotherapy and prostatectomy? We need to have a good medical history, past treatments, radiation exposure, general health status. Then the patient is always evaluated with a visit, a urinary function, and with an imaging that may include urodynamics, ureterocystoscopy to exclude the urethral stenosis, and sometimes ureterocystography, so radiological imaging, to better determine the severity of the incontinence. The sling implantation is done under general or spinal anesthesia. The surgical procedure provides perineal incision and the urethral exposure, and the sling then is positioned around the urethra and secured to the surrounding tissues. Usually, the sling is a transobturatory sling. During the surgery, the surgeon can adjust the tension in consideration the severity of the incontinence and in consideration of the radiation therapy. From large meta-analysis, these are the results of outcome and complication of male sling implants in radiated patients. In radiated patients, we can have a good success rate that ranges between 70 and 80%. This depends many times from what we mean for success rate. If we mean zero pads use as a success rate, maybe we don't reach the 70%, but in some studies, for success rate, they mean an improvement in the continence. So then you can reach the success rate. But honestly, in radiated patient, the success rate is not so high. In this scenario, the best thing is talk with the patient and offer a sling only when the patient is not so motivated for an artificial urinary sphincter. On the other hand, we have a good complication rate that ranges from 5 to 10%, and potential issues include infections because the tissues are more fragile after radiotherapy and more exposed to infections, sling erosions, or need for revision of the sling. When the sling is eroded, they need to be removed surgically. Due to infections and the sling erosion, the patient may not be satisfied because he has not reached his goal. Often the patient's goal is not to use any pad, so to be completely dry. And in many cases after radiotherapy, the patient is not completely dry, and he has also some complications. So it's very important to, I'm repeating myself, but it's very important to talk to the patient before the surgery and not after. The challenge is to manage not only the preoperative scenario, but also to propose to the patient a tailored approach, to propose the sling in selected patients, talking about the complication that may be increased, talking about the success rate that may be lower than normal, and talking about possible alternatives. There may be other devices or the artificial urinary sphincter. And what to do when the patient is not satisfied or when the incontinence recurs after sling implantation. The patient often needs a further assessment with instrumental exams to identify the underlying causes of the persistence of the incontinence. The sling may be revised or reimplanted, or we can propose to the patient other solutions, such as artificial sphincter or other therapies. And also the patient can be educated to manage the symptoms and his lifestyle. Thank you for your attention.
Great, thank you so much. And now we're going to move on to our second presentation given by Professor Sacco.
So thank you very much for this opportunity to contribute to the EUROGEN network and to contribute to the care and education in male urinary incontinence. So we will talk about artificial urinary sphincter in this complex scenario of radiated patients. These are my conflict of interest. So we will have an introduction to artificial urinary sphincter, and then we will talk about challenges in these patients, published evidence, perioperative considerations, and conclusions. So artificial urinary sphincter is a silicone-made three-component device, at least looking at the most used device, that is the AMS 800. Anyway, any type of artificial urinary sphincter acts by a circumferential compression of the urethra, usually at the level of the bulbar urethra, and the functioning is mechanical in nature because the patient has to use a control pump in order to urinate. As you can see, the AMS 800 is consists of three components, so the cuff, the control pump, and a reservoir. The device is customizable because you can choose a different type of cuff based on the size of the patient urethra and a different type of pressure of the balloon, and you can customize the length of the tubes. Artificial urinary sphincter is the gold standard, is considered the gold standard and the gold reference for the treatment of stress urinary incontinence. It reached the level A recommendation in the last international consultation on incontinence and the level 1B evidence in last European Association of Urology guidelines. This level of evidence is mainly based on a randomized trial, the master trial, that compared male sling and artificial urinary sphincter and demonstrated the efficacy of this device. Although, as you can see, the percentage of incontinence patients is quite high. Anyway, the definition of continence in this study was very strict. So after artificial urinary sphincter, most of the patients have some leak, but the rate of improvement is very high. And as you can see, looking at the subjective outcome in this trial, about 90% of the patients were satisfied after the implantation. Here you can see the most critical step of the implantation, that is the isolation of the bulbar urethra and the positioning of the cuff. This step is even more tricky in radiated patients, especially at the level of the dorsal aspect of the urethra, where you have to free up the urethra from the corpora cavernosa. At this level, the urethra is it can be very attached to the corpora cavernosa, especially in radiated patients, and so a urethral intraoperative lesion can occur. The device is effective anyway. There are some possible complications, especially in the long term, tissue complications such as infection and erosion, and also urethral atrophy and constrictive periurethral capsule formation. Urethral atrophy and capsule formation can cause recurrent incontinence in the long term. There are also possible mechanical complications, especially balloon malfunctioning due to material fatigue in the long term. Fluid leakage, tubes leaking, pump malfunction today are quite rare. Because of this complication, there is a non-negligible rate of explantation and overall reoperation because of recurrent incontinence or erosion and infection in the long term. About in these quite large series, about 28% had an explantation at 15 years, and more than 1/3 a reoperation because of recurrent incontinence or complications. So let's look at the challenges in artificial urinary sphincter implantation in radiated patients. We know that the radiation has several consequences on tissues, such as chronic ischemia, such as chronic inflammation, collagen deposition with scar tissue formation, and tissue stiffening, especially at the level of the urethra. The radiation impact on healing process, and all these effects are progressive in nature. So the way for radiated patients from incontinence to continence can be quite complex because of difficult surgery, and the surgery can be difficult, especially because of previous treatment. Most of these patients had, for example, previous sling, and because of fibrosis due to radiation. Also, the healing post-operative healing process can be more complicated in this patient. The risk of decreased efficacy is higher because of fibrosis and ischemia, also because of ischemia, chronic ischemia. The risk of infection and erosion is potentially higher in these patients. Other factors can complicate even more the scenario. In radiated patients, we can observe radiation cystitis, recurrent urinary tract infections, especially recurrent refractory bladder neck or urethra stricture. And also there is a risk of secondary bladder neoplasia. All these complicating factors in radiated patients increase the risk of bladder instrumentations, and so the risk of urethral lesion after artificial urinary sphincter implantation. Anyway, looking at the literature, most of the literature on radiated patients is basically retrospective in nature. So we have quite a lot of studies, but mainly of low quality. And so based on the last international consultation of incontinence, prior radiotherapy is still a gray zone needing further investigations. And in the last international consultation of incontinence guideline, the artificial urinary sphincter is an option in radiated patients, but radiation may be a risk factor for increased complications. So looking at the published evidence, in particular looking at the efficacy of artificial sphincter in radiated patients, here we can see a quite large retrospective study, more than 600 patients by Ray and the co-authors, about 95% of radiated patients. The failure rate was very high in this patient, about 80% compared to 5% in non-radiated patients. So with an odds ratio of about 4. This is another study, single center retrospective study with a multivariable analysis that showed radiotherapy as an independent prognosticator of failure together with urethral stricture, previous link, and coronary disease. And this is the last meta-analysis on the efficacy of artificial sphincter in radiated patients. As you can see, there is quite a lot of heterogeneity. So the different studies are controversial with contradictory findings. Anyway, the summary result is a higher risk of failure in radiated patients. And in based on this meta-analysis, the last European Association of Urology guideline report that the prior pelvic radiotherapy is likely to have a negative impact on the outcomes of artificial urinary sphincter, although the level of evidence is only 3. In the same meta-analysis, also an increased risk of explantation and erosion is reported in patients, in radiated patients. And there is also trend for an increased risk of infection. In this study, looking at the erosion risk, prior radiotherapy was associated with a quite high relative risk for erosion, relative risk of about 3. And in this series, also the explantation rate was higher in radiated patients compared to non-radiated patients, and the history of radiations was an independent predictor of infection and erosion. So these several retrospective series with large or quite large sample size that confirm these findings. This is a very large multi-center retrospective study confirming an higher risk of infection, erosion, and explantation, again, in radiated patients with quite long-term follow-up. And the risk of explantation is higher not only after the initial implantation of the sphincter, but also after the second and probably also after the third implantation of risk. So when based on this study by Fuller and co-authors, the risk of explantation remain higher in this patient also in the second and third implantation. So let's look at some perioperative considerations in these patients. Preoperatively, it's very important the assessment by cystoscopy in this patient in order to look at the quality of the tissue, in order to look at the presence of stricture at the level of the urethral bladder neck, and the quality of the tissue, so presence of fibrosis, scarring, poor elasticity, because all these findings can affect efficacy. Also, the urodynamic evaluation, I think, is even more important in these patients, although we have no clear evidence on the usefulness of urodynamics in male urinary incontinence. Anyway, this patient, because of radiation, can have low capacity, low compliance, detrusor dysfunctions. So I think it's very important, especially in this group of patients, to obtain urodynamic findings. The risk of infection is potentially higher, so it's important to perform urine culture before surgery, and probably to use broad-spectrum prophylactic antibiotics in these patients. Prolonged antibiotic prophylaxis is not justified, but broad-spectrum one-shot prophylaxis is very important. Patient comorbidities also can be addressed preoperatively in order to decrease the risk of infection, especially diabetes, cardiovascular disease, immunosuppression, and pharmacotherapy. Looking at intraoperative and postoperative consideration in radiated patients, to stick to a very strict aseptic technique is very important, especially in these patients with a potentially increased risk of infection. It's important to minimize the tissue trauma, so don't perform a very large, very big incision, and avoid unnecessary resection of irradiated tissue. The appropriate cuff sizing is also important. I advise to not use too small cuff in these patients because of the higher risk of erosion. The post-operative care, post-operative follow-up monitoring is even more important in radiated patients. Immediate controlling of infections is absolutely critical, and so stick to close follow-up in order to detect very early any sign of erosion and infection. Here you can see a case of radiated patients with very atrophic urethra, recurrent incontinence. In this case, you can perform capsule incision in order to increase the urethral size, and you can replace the or smaller cuff or use another side of the urethra to reimplant the cuff. And this is another case of erosion in radiated patients, and these patients had just an episode of hematuria and then recurrent incontinence. So perform cystoscopy in every patient that report recurrent incontinence or hematuria, especially in radiated patients. This erosion occurred after 2 years from the implantation. And here, another case of erosion after 5 years from the implantation. And here you can see a complete erosion of the cuff. The cuff is completely into the urethra, and the patient had the recurrent incontinence, but the urological observation was consultation was quite late, and should be another video. So let's go. And here you can see the surgery where we removed the cuff, performing a small urethrotomy, and then we perform urethroplasty and reimplantation after 6 months. So I always perform not only in radiated patients, but in every patient, the transalbuginal implantation, because as you can see, the albuginea of corpora cavernosa is a multi-layer structure. So there are at least 2 to 3 layers. So you can isolate the urethra dorsally, enter inside the albuginea, and leaving the most external layer of the albuginea attached to the urethra in order to decrease, especially the risk of intraoperative urethral lesion. To decrease also the risk of erosion, at least dorsally. And I suggest this technique in every patient, especially in radiated patients. And here you can see this step of urethra isolation. We usually start 4 to 5 millimeters laterally to the urethra. And finally, as you can see, a small layer of albuginea is left attached to the dorsal urethra. We published this series on 47 patients with very encouraging result. We did not observe intraoperative urethral lesion. So what we can do in patients with recurrent incontinence after artificial urinary sphincter implantation, or in patients with erosion or infection. Here you can see several options. We usually replace the full system if the system has been implanted more than 5 years ago. This, I think, is the best option in patients with recurrent incontinence. You can also perform cuff relocation in case of recurrent incontinence, putting the cuff more distally or more proximally. And this is one of our preferred option. You can perform cuff downsizing, although we don't use the 3.5 centimeter cuff because of increased risk of erosion. By performing capsulotomy, sometimes you can obtain a larger size of the urethra and so put a cuff larger than 3.5. Transcorporeal implantation is another important option to know. Double cuff is an option that actually we don't like because double cuff means double rate of complications. Reservoir substitution is with a balloon with higher pressure is also an option, but I don't suggest this option in radiated patients because of increased risk of infection and urethral wrap. Here you can see a cadaveric dissection with all the possible cuff location. So you can use in patient with erosion, especially a more distal location of the cuff, and the distal urethra is usually also less involved by radiation changes, so you can use this site in patient where the bulbar urethra can't be used. Looking at transcorporeal implantation, the published literature is mainly of low quality, mainly retrospective single-center study. And anyway, this technique is very important to manage, especially in radiated patients, because in some very tricky scenario with a lot of fibrosis, it can help to put the cuff without intraoperative urethral lesion and obtaining a larger size of the urethra. Anyway, potent patients must be aware that this technique can impair erectile function. Some authors suggest the urethral wrap using several types of graft materials, cadaveric dermis, small intestinal submucosa, but I don't like this option because of possible postoperative inflammation and especially reabsorption of the graft in the long term, so with the risk of recurrent incontinence. This is our algorithm that we usually use in our everyday practice. We usually suggest artificial urinary sphincter in patients that have BAF, moderate to severe incontinence associated with one complicated factor, such as radiotherapy, but also previous incontinence surgery or previous surgery for bladder neck or urethral structure. Anyway, we suggest sling as a first option, also in radiated patients with mild, less than 300 milliliter per day of urine loss, so with mild incontinence. Of course, patient preferences and the patient expectations are very important in this scenario. So in conclusion, artificial urinary sphincter remains a viable option for managing urinary incontinence in radiated patients as well. Of course, radiation induces fibrosis and ischemia, can affect BAF efficacy and complication rates. So a careful consideration before, during, and after surgery is required. This patient should be treated in high volume centers, I think, because of the more complicated surgery and because of more strict follow-up. Optimal outcomes depend in these patients on very careful preoperative evaluation and counseling. Counseling is of utmost importance. And lastly, we still don't know the relationship between efficacy and complication and radiation dose, radiation fields, and the type of radiation. So further investigation are needed in this field. Thank you very much for attention.
Thank you very much for your nice presentation.
There are questions.
Yes, indeed. I would like to open up the discussion section of the webinar. So if you have any questions, please feel free to type it in the Q&A section. So you would have a button with a question mark in it with Q&A. So there you can type your question. Yes, there's one question already.
A question here by Kate. So if a patient is found to have a bladder tumor and needs TURB with resectoscope, do you recommend just deactivating, or do you even have to explant the cuff? So these very interesting questions, especially in radiated patients, because we know that the risk of secondary bladder tumor in this patient is low, but anyway, is not zero, is higher than the general population. Usually, in these patients, you have to perform the TURB with a smaller resectoscope. You have to deactivate, of course, and very gently try to enter with the resectoscope. But usually with the smallest that you can use, without, for example, using the sheath of the resectoscope. If this is impossible, you can just open the cuff. So you have to incise the perineum, go to the cuff, open the cuff, and then perform the endoscopic procedure. So this is quite, of course, complicated procedures, but sometimes can be the only option, because the other option is to go percutaneously, but of course is not a good option in patients with bladder tumor. I don't know if Riccardo agree.
Yeah, of course. The explanation.
So I can see
another question. Yeah.
Okay. Thank you for presenting. What type of artificial sphincter do you use? I always use the most used model is AMS 800. We know that other models are on the market, but based also on the result of the Saturn registry, AMS 800 is absolutely the most used, at least in Europe, but I think also in United States. Anyway, in some centers, there is there could be good experience with other more recent model, but of course you need the special experience using a model that have not the evidence of the MS 800.
Very well, thanks.
I think also Riccardo has the same.
I use the same MS 800 as recommended, the most. She
have about 50 years of experience with MS 800, and other model of artificial sphincter with very interesting features are under development at an early stage of the development. very interesting is the possibility to modify the pressure of the sphincter based on the patient activities, such as sleeping, for example. We know that usually patients in the lane position, usually they don't leak, so this new sphincter under development look at the possibility to decrease the pressure during the sleep, and this can reduce the risk of erosion, maybe, but we are in an early stage of development.
Nice. So that's something that we can look forward to in the future.
Yeah.
Very well. I will wait a couple of more minutes that people can type in their questions if they have any. In the meantime, I would like to mention that this webinar has been recorded. So I will be sending the link for the recording tomorrow via email, and I will also post it on our YouTube channel. So make sure you subscribe to our YouTube channel to see all our past webinars over there. And you can find a list of the past and the future webinars that are upcoming on our website. So as Michelle mentioned at the very beginning of the webinar, this webinar is eligible for CME accreditation points. So if you fill in the survey immediately after the session has finished, you will not only help us continuously improve our sessions, but you will also receive the certificate. You will receive the certificate in about 2 weeks' time, so you won't receive it immediately. No.
I just have a question for Riccardo. What do you think, Riccardo, about radio procedure, wrestling, that is an option in the general male incontinent population? What do you think about wrestling in this complex population of patients?
Thank you for the question. What I think that this may be an option, but if requested by the patient, from a patient who is not eligible for an artificial sphincter, and the efficacy may be very low. It's a radio procedure. Tissues may be very scared, also by radiation therapy and by previous surgery. So the efficacy, I think, is not so good, but may improve the continence in some kind of patients. So it's may be proposed to those patients who are not eligible for artificial sphincter.
What about adjustable sling as a...
Adjustable sling may lead to many complications, and there often are more than benefits. So I'm not so according to use adjustable sling, and I prefer fixed sling.
Thank you. I agree with you. I think the complication rate is usually higher compared to fixed sling, and I think it is even higher in these complex population patients. So in radiated patients with recurrent incontinence after sling, I always suggest artificial urinary sphincter.
Any other question from the audience?
I don't see any new questions. So I think that was it. Perfectly on time. It's 7 o'clock. So thank you so much for the interesting presentations and the discussion. And I would like to thank the attendees who have joined us this evening. And hereby I would like to wrap up this session. So have a good evening, and we will see you all at our next webinar.
Thank you.
Bye.
Bye.
Thank you.